Hello and welcome to Digital Health Off the Record, your podcast for the latest clinical technology trends, news, and unfiltered insights. I'm Farrell from ObsRO. This is Tato, who's my co-worker, and this is my colleague Edwin.
Hey, and good morning, good afternoon, everyone. Yes, Edwin from CMFlow, and yeah, proudly the co-host for this podcast. Um, I'm going to say something and thank all the listeners first and the ones who subscribe for following us. We're doing this with a lot of fun actually, and really enjoy all the prep work that we're having in advance of these meetings. And for today's podcast, we're going to deviate from the trends and not talking about AI so much, but really something digital that has been here for quite a while, but hasn't, from my humble opinion, reached the full potential yet, which is eCOA, so the electronical clinical outcome assessments. And what we're going to do today is describe and focus on some of the benefits. Um, Also, as we always start, bringing it down to the basics, explain a little bit what it exactly is and how things can be differentiated and what's close to us and where we believe things struggle a lot is talk about where things struggle, where it becomes difficult, and it mainly has to do with implementation. So we're going to do a deep dive on these sessions and areas. So as said, as always, we're going to focus to the basics. And Farrell, can you help explain the people who are listening to us what is eCOA exactly if we talk about eCOA? Because it's such a huge umbrella term.
It is indeed, and it is a lot more than just ePRO, which a lot of people may think or get that focus more on the ePRO side, which is the patient-reported outcomes. So it's where, and it can cover a bunch of different areas as well, depending on what you want to do, because it's more than probably just the eco side of it as well. So the three or the four main sections for eCOA are ePRO, ClinROs, ObsROs, and PerfOs. So the ClinROs are the clinician reported outcomes as well. So the sites can complete the questionnaires that will give a validated assessment of the patient's condition. And similarly, the ObsRO is where it's an observer reported outcome. So it's where somebody other than the patient is making an assessment. So quite useful when it comes to things like pediatric studies or where there might be the need for a carer. So where somebody doesn't have the autonomy to respond themselves. So it's not self-reported in those cases. And then you've
Mhm.
got perfos, which are performance outcomes. So it's where there are specific performance tests that can measure what your performance are. So think digital 6-minute walk tests or any cognition type testing for the neuro spaces.
Yeah. Are these questionnaires used for primary or secondary endpoints, or can it be both?
It can be all of the above. Excuse me. So since they're validated questionnaires, it depends on where there's been that level of proof. So obviously you're not going to jump straight in with a new questionnaire straight to your primary or secondary.
Mhm.
But as you mentioned, they've been around for such a long time now. They've got to the level of acceptance where they're now being used for prime time for primary and secondary because they've been proven to be a good measure of specific conditions and capturing the patient voice in particular when it comes to how they're feeling as part of their condition.
Okay. And what about remote patient monitoring or eDiaries? Are these equal to eCOAs? Or and if not, where do they differ?
And that's where it can be beyond eCOA these days. So where the eCOA are validated questionnaires that are specific to their condition or so on. things like eDiaries, where you can have like symptom capturing, so you're capturing data directly from the patient. So whilst it's not a validated questionnaire or owned by a specific license holder like the eCOA solutions, at the end of the day, it's all part of the patient data capture, remote or not. And similarly, RPM, so remote patient monitoring, similar kind of situation. You're trying to keep tabs of how the patient is outside of the clinic. So trying to find, what symptoms they're having and any other information that could be useful for doing a clinical judgment as well.
Yeah, great. Thanks for sort of making this distinction and that we don't, I think for the audience, make the mistake to just call everything eCOA or call these like questionnaires, for example, because there's definitely a huge difference between all of them. So when we look at and talk about eCOA, the E obviously stands for electronic. Can you elaborate a little bit on maybe a little bit of history about sort of when it started and so forth? And as we used to have this all on paper, and I still hear people talk about, please give me paper.
Absolutely. Yeah, still have those cases come up, and it's definitely not in the new technology category. So it's been around for well over 20 years now. I've been doing it for 14 years, and when I was starting out, some of my first tasks in the eCOA field was working with a Palm Pilot, which might be a bit of a legacy call out for some people, and trying to get data off of it using a fax machine connection. So there's another side of it too. So
Yeah,
it's really evolved from sort of where it started out using the older technologies as well. And as well, when it comes to clinical outcome assessments, they've been around for much longer. They've just been paper previously, right? So this
yeah,
is eCOA is where you make it electronic and digital and bring all the benefits that come with that. So you have Alcoa Plus principles, which tie into it being e-source rather than a paper source. So you can see timestamps, you can see the audit trails, who completed it, and so on and so forth. So there's a lot of big benefits that come with that migration from paper, where the data integrity maybe not so well versed there, compared to having an e-source.
yeah. And what does it do with cost, for example? Does it eventually reduce costs because adding additional sort of vendors, technology, training is adding up as well now?
Absolutely. It's kind of like more a case of where do you put your costs. So I think it's been proven to bring cost benefits. So if you think of it from different angles, so if you have paper, you think that's cheap, and then you have technology, clearly that's expensive.
Yeah,
It's kind of like you're front loading your cost for downstream benefits. So when you think of paper, you're not acknowledging somebody's going to have to manually transcribe that into a system so you can analyze it, which is
yeah,
time, money, effort. Also, beyond that, it's the how much is the quality of your data or the amount of data you capture worth? Because with eCOA, you can do real time data monitoring, so you can see when patients are maybe not completing, and you can do follow-ups to make sure that you're
hmm,
capturing the data necessary, compared to
yeah,
paper, which you have absolutely no visibility upon it.
yeah,
So, and if the cost of delays for studies, it ranges from, I think I've seen a paper that said between $0.6 million to $8 million a day. So if you need to extend your study because you don't have sufficient data, it can be very
yeah.
costly.
Yeah, if people would use common sense, or if we all had the same common sense, this is a logical step to take, though, and a no-brainer for sure. Last thing I want to mention is sort of the word or the phrase that's going on within eCOA specifically, I believe, is the parking lot syndrome. Can you explain to people who have never heard about this or where it resonates a little bit what this exactly means in the line of eCOA?
Yeah, absolutely. So with eCOA, obviously everything is time-stamped and you can tell exactly when it's being captured, and there's some ways to prevent you capturing outside of the appropriate windows. So parking lot syndrome is where there's a wonderful phenomenon of humans acting to try and avoid getting on the naughty step. So the patient hasn't completed all these big stack of paper diaries for the last 2 weeks since their last site visit. They get to the hospital car park and then they start filling everything in because they don't want to get told off by
Yeah.
the investigator. So it's where they're trying to do recall, which it's not going to be a very fair reflection because at the same time, if you ask them like three
Yeah.
nights ago, what did you have for dinner? They're not really going to be able to remember that too.
Yeah. Yeah. So it's not considered to be just-in-time management, like delivering everything
Exactly.
on a timely manner. Yeah, that's something definitely human. If if you may, we switched gears. We talk about electronically, and we can deliver this to our patients in different ways, either providing them with a handheld device or nowadays is already a little bit longer in place, but
Hmm?
for them to utilize their own device. Can you elaborate on this a little bit? Sort of first of all, when does a study team or a company makes the decision whether to use one or the other?
Hmm. And that's again down to, how do you want to manage your cost as well? Because if you're using bring your own device, it can be a lot cheaper because you're not having to absorb the cost of procuring a bunch of devices, whether it's on lease or whether it's purchasing outright. But the more expensive part typically for a longer term study is, the data allowances and SIM cards, which really adds up when it's a per patient, per device, so on. But there's been a lot of good research and proof and done by lots of different groups, including I think CPATH did a lot of work that shows there is that equivalence and acceptability between provision devices and bring your own device. So one of the previous big concerns was if the questionnaire isn't exactly on the same size screen for every single study, or every participant in the study, is that going to change the data and introduce bias? Which a lot of those
Hmm.
studies have proved that that's not the case, and it's pretty much it has the same level of equivalency testing as well.
Yeah.
But at the same time, not everybody has a device that might be capable. So areas where you want to consider having your provisioned, and you should always have a certain degree of provision devices allocated, is somebody doesn't have a appropriate device, or even down to patient preference. They might want to have that degree of separation between their treatment, compartmentalize that to, okay, it's on this provision device, so that they're not seeing your eCOA app as they're going through their day to day as well.
Yeah.
So there's many different areas to consider when it comes to that. What should be your operational
Yeah.
strategy?
Yeah. Do you know, by the way, whether we as an industry compensate participants in the usage of their own device? Because it consumes data,
Mm-hmm.
and not everyone has the luxury to buy the most expensive contract and these kind of things. Is this something that is commonly taken care of?
I would say not commonly. It's something I've been fighting for a lot in my time, and it's only fair at the end of the day. So whilst a lot of the eCOA solutions, the questionnaire side of it doesn't really take much data at all. But if you think of some of the other benefits that people are trying to get out of these solutions, like adding in lots of patient engagement and training videos and so on, it really can add up. So whilst there's a push to you should connect to your Wi-Fi, you may not always be on Wi-Fi, right? And especially if you're
Yeah.
traveling too. So it's definitely an area I think sponsors need to be considerate of, and as
Yeah.
well for the eco
Yeah.
suppliers to be able
Yeah.
to say how much data typically would be used and
Yeah.
allowing that to be reimbursed.
Yeah. Yeah, I'm addressing this because I feel that we as an industry tend to forget sort of the 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 impact these kind of things will have on patients, and these could be as really simple things. Also, like data uses data protection to have something installed on your app that is not something you deliberately choose to install, etc., etc.
Exactly. Because there's no better, faster way that you'll lose a patient to follow up, and you won't be able to retain them if they
Yeah,
can't, send
yeah,
messages to their loved ones because they've used
yeah,
all of their data on the eCOA as part
yeah.
of their treatment.
Yeah. And the last thing I wanted to address around sort of the BYOD is from a sustainability perspective. What's what's the best scenario here?
I mean, it depends on how you approach it as well, right? So, depending, because sustainability can mean lots of different things. So obviously, there's less of a carbon impact to bring your own device because this device already exists, etc.
Yeah,
But at the same time, a lot of the cases, the provision devices might already exist. So you're probably a bit carbon neutral at that stage. But there are some areas that you could look into from like a corporate social
yeah,
responsibility side. So once you've finished using your provision devices, you might be able to donate them to like a local school or community, recycle them as well. But obviously that does have an impact too. So you need to make sure that you're
yeah,
considering it. And as well, provision
yeah,
devices, you need to ship them to where about the world.
yeah,
So that also has an impact.
yeah. Yeah, I've experienced that as well, and that's quite cumbersome, those processes. So people tend to say, well, just destroy them, even though it's for a good cause.
Yeah.
And the latest feedback I received from sites was that, okay, we've got a huge pile of devices here, and we need to use one device per study. And there's a lot of legacy devices there from studies that have stopped for ages.
Hmm.
They're never going to be retained, and yeah, that's another good reason for bring your own device. But I hope in a couple of years that will be easier to solve.
Absolutely.
Yeah. So moving to the, yeah, I would say the last sort of high and key thing for eCOA, it's about implementation. We both strong believe that if things go wrong, it goes wrong in the implementation.
Hmm.
I'm not going to call them all out, but start where would you start saying where are the things that people need to consider and hence are the key sort of challenges.
So the one that always comes up is about licensing, translation, and submissions. So they're kind of all in that single kind of bucket. And it's where people can get a bit stuck and why they start asking for paper. So with the licensing and translation side, so where it's a validated questionnaire and has a specific license holder and copyright holder, you need to go and get agreement that you can use it as part of your study. But the problem is these can vary from, a very well-oiled supplier that this is what they do, but it can also
Yeah,
go to that university researcher. It's one person, they're managing their inbox whilst they're being a professor, doing everything else, and they may not respond as much. So it's that kind of connection of
yeah,
there is such a, how long is a piece of string when it comes to how long does licensing take, because it depends on which questionnaires you're using,
yeah,
which authors you happen to work with.
yeah.
Then in turn, they have to provide the translations. And if that translation for that questionnaire doesn't exist, then you
Okay,
have to go and do linguistic
okay,
validation on top.
yeah. Can you understand that like a person like me doesn't really understand why this is still like an issue? And are there no initiatives taking place to really make this a lean process and make this as efficient as possible?
Well, it's that's the challenge. It's just very variable. So some previous initiatives I did was just trying to do early engagement, shift the efforts left so that it's totally off your critical path. But I know that CPATH have been working to try and set up a consortium for license holders and translation suppliers so that they can try bring some standardization and
Yeah.
standard way of working and how to make this work more seamlessly.
Yeah. Yeah, because it's as you said, it's on the critical path. Obviously, it helps if you can sort of remove it from the critical path, but eventually you need to have it all as part of your submission and startup. So,
Mm-hmm.
and if that's causing generally delay, it's causing the overall industry and not only the industry, but the uh, people in general. It's costing so much money, which is
Mm-hmm.
yeah, a little bit of a shame for sure.
Exactly.
Yeah. And I see that we don't have extended a lot of time anymore to go through all the things. I want to touch upon sort of China actually, because we talk about sort of US rest of world, but China is not considered to be part of rest of world. What's
Mm-hmm.
sort of the challenge overall there?
So with China, they have obviously a lot of data privacy and data storage kind of rules and regulations with their EGFR. Is that what the regulation? Can't remember off the top of my head, but also it goes down to technology as well because they approach technology very different to the rest of the world. You know, they where they've got Tencent and WeChat. Basically, all their apps fall into a single app, which is kind of just how they work, which in turn has an impact to they don't have app and play stores over there. So it's not a case that where you have to bring your own device, you upload it to the app and play store, participant downloads it. So they have a different way of managing apps over there. So it's not something that you
Yeah,
can easily do. So often you have to try and find a process where you can procure devices within the country, get it installed within the country, and then supply it. So you may need to have more of a provision device approach there. But I'm sure there are now also a lot of China eCOA suppliers as well, because it's been booming in the industry. It's where the most new studies are coming out of at this stage.
yeah, yeah, definitely. Would you recommend always to have a dedicated person in China focusing on these activities? As it
Um,
sounds pretty complex, or is it eventually straightforward?
well, it depends on the approach that your eco supplier is working on. So they should have a way that works for them. So because ultimately it's how do you tackle that? Which there's many different ways. So you'd have to consult with your supplier to see how that works out. Whether it's
Yeah,
they have an entity and a location within China that they can ship things out, or if they need to send something to um, to a specific hub for you to distribute from there, so on.
yeah, yeah, indeed. Yeah, from my perspective, I would say you need to have someone then local to understand sort of how this all runs, because
Mhm.
from an outside, that's quite complex. Um, any other sort of a couple of things you just want to touch lightly on when it comes to sort of overall implementation?
Yeah, I think it's a big thing for me is if you are paying the money for the eco solution, it's how do you maximize the value out of it? Because ultimately, compared to paper, it should be bringing benefits to the patient in terms of, the technology is there. So, for example, using digital accessibility tools. So if they're hard of sight, that they can have like increased font sizes, or if they're colorblind, that they can have settings turned on, or even if they're maybe unable to read, doing things like text to speech so that they're able to hear the response rather than having to read it as well. And then also there's things to consider along the way as your study progresses too. So how to have things like caregiver support or assisted completion, so that even if it's a natural progression through your study or if it's a separate need, that somebody can complete on behalf of the patient, whether it's direct transcription or, what they're interpreting. So where maybe the patient's cognitive ability is declined to the point they can't respond themselves, that somebody can log in and do that for them instead.
Yeah. Yeah, this sounds really like where digital is going to be a huge differentiator to sort of definitely paper and where sort of the added value definitely is. Um, yeah, I think we touched upon quite a good of good topics around implementation. Any final things you want to sort of share and give to the audience?
Yeah, just it's 2026. uh, you know, paper really. Um, so there's so many hidden costs, and there's so much more benefits you can achieve through eco at this stage
Yeah,
that it shouldn't really be much of an argument anymore.
yeah,
In fact, the amount of risk that you're introducing but to your data integrity, it's definitely not going to be worth it at this stage too.
yeah,
So when it gets to submitting.
yeah. No, I echo what your thoughts for sure, and yeah, I wouldn't go backwards for sure. Um, I think this brings us to a close for this podcast where we focus on eCOA. The next topic is going to be having a similar type of discussion actually, where paper versus digital is even more prominent. And it's e-consent that we're going to talk about. And I think we're going to switch the roles a little bit, although we are both sort of supportive of obviously e-consent. But yeah, that's where we're going to focus on in the next podcast. So really looking forward to the prep and for bringing that knowledge to the listeners. Farrell, anything for you to close with for today?
Just thanks for listening, and yeah, feel free to engage. Let us know your thoughts. Let us know if there's any topics as well that you'd like us to cover, or if you would like to join us at some point too. So thanks, and yeah, don't forget to like and follow and connect with us on LinkedIn. So thank you, everyone.
Super. Thanks.
Bye.